A lot of physicians believe that having a platelet count at 50 or below protects you from DVT, and that's not actually the case. Having a platelet count below 50 significantly increases your risk for bleeding, and giving these patients chemoprophylaxis can certainly add fuel to the fire if they do have a spontaneous bleed. Like I said, there's a lot of comorbidities at work there, like obesity, limited functional status, if they have peripheral vascular disease, that really need to be weighed in the setting of determining whether or not that patient needs thromboprophylaxis. And I've seen it been given down all the way down to 30.
Welcome to Critical Care Time, the podcast for everyone who cares for people with critical illness. I'm your host, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. On this week's episode, we're going to talk about an intervention we perform every single day in the ICU, but we don't think about nearly enough, namely prophylaxis to prevent venous thromboembolism.
And today we are fortunate to be joined by an expert to help us discuss this topic, a dear friend of mine, Dr. Matthew Rendo. So Dr. Rendo is a hematology and oncology physician who completed residency in internal medicine and then fellowship in hematology oncology at Brooke Army Medical Center in Fort Sam Houston, Texas. He currently works in Ohio, where he sees clinic and does inpatient hematology and oncology. He's an early career physician, just like we are. And he's a researcher as well. He's published works ranging from prolonging use of cyproheptadate to describing novel treatment modalities for malignancies. He has done a tremendous amount in his career thus far, and we look forward to seeing him do a whole lot more. If you like pictures of blood smears or other wisdom, you can also follow him at Rendoncology, so RENDONCOLOGY, on Twitter or X or whatever it is today.
Matt, welcome to Critical Care Time. Anything else you want the audience to know about you before we get the show on the road?
Thank you very much. I'm really excited to be here. And just as Cyrus said, I trained with him when I was an internal medicine resident, and then we did dual fellowships as well. As you said, I'm a hematology oncology doc, Kansas City native, graduate from the University of Missouri. Interests in thrombophilias, vaccine efficacy in the setting of malignancies, and just recently studying environmental exposures associated with malignancies. And beyond that, I have no real world skills to speak of.
You are so full of it, man. Well, I think, like I said, we're super excited to have you, Matt. It's always great to see a friendly, familiar face. We've got a ton of great content that we want to get to. So, Nick, how about kicking us off with a case? Why don't we plan to just go case by case and knock out our goals one by one? How's that sound?
Perfect. All right, Matt. So we got a lot to cover here. Let's start off with an easy one. Let's say I'm admitting a 77-year-old man. He's got a history of hypertension, diabetes. He's in the hospital for septic shock with a urinary source. He's on the right antibiotics. We put him on some peripheral norepi to maintain a MAP above 60. That's running at a low dose. Got all these orders squared away. I finished my note. And then I realized, wait, I forgot to put in DVT prophylaxis. I should also mention he has a creatinine of 1. First off, how big a screw up is it to forget DVT prophylaxis? Can you help us understand that?
Especially for this guy. He's coming into the ICU. He's septic. He's going to be high risk for either DVT or throwing a VTE and a PE. And really, PE in the ICU is something that's believed to be significantly underdiagnosed. When you look at autopsy studies, anywhere from 7 to 27% of these patients who are critically ill at the time of their death have PEs. And a lot of times it's really hard to tease these apart. These patients are ventilated, they're sedated, they're critically ill. They can't always inform you, hey, I'm having chest pain, I'm significantly short of breath. You might not always see hemoptysis in the setting of being ventilated as well. When you look at meta-analysis data for patients who are in the ICU and develop DVTs on no thromboprophylaxis or mechanical thromboprophylaxis, the rates of DVTs are anywhere from 13 all the way up to 32%. While those who are on unfractionated heparin prophylaxis, you see rates from 5 to 9%. And there's a lot of potential data out there as well that indicates that PE is believed to be the most common preventable cause of hospital-associated deaths.
Just to emphasize that point, Matt, because I think that's a really important key takeaway for our listeners. PE is the number one preventable cause of hospital death. It's probably an even more significant cause of death in ICU patients, where as many as a quarter of them have a PE at time of death, in many cases unrecognized. And the benefit that they derive from DVT prophylaxis is enormous. It's like, a reduction, you said, from like 13 to 30% without treatment to 5 to 9% with. So huge effect size.
Yeah, and one of the things I think it's always important to look at when you're instituting a treatment is how many patients you need to treat in order to get a therapeutic outcome for that. So specifically the number needed to treat. And one of the studies I like to quote is the Artemis trial. It looked at fondaparinux versus placebo in critically ill patients who were at least bedbound for 4 days that showed VTE rates of 11% in the non-prophylactics patients versus 6% in those who were receiving fonda, with a number needed to treat in that trial of 20%. Number needed to treat in that trial of 20 patients.
Excellent. That's definitely a good one to keep in the back pocket when we're considering DVT prophylaxis in these folks. Now, it's interesting that they used, they used fonda in that study. Any insight as to why they used fonda? That's not typically my go-to for DVT prophylaxis in the ICU.
On that study itself, I'm not sure exactly offhand why that one. They looked at fonda versus placebo. There's been a couple other meta-analysis datas sets that have come out. One was in Blood in 2006, and they looked at 8 trials. They looked at low molecular weight versus placebo in that arm, and they showed the risk of DVT decreased by 42% in those that were receiving low molecular weight. And the number needed to treat, and in that meta-analysis, looked like it was around 46.
Awesome. So there does seem to be data, not just for fonda, but it's been looked at also for something maybe more commonly used like low molecular weight heparin.
Yes. Yeah, and low molecular weight heparin is pretty much a standard for a lot of inpatient admissions. Fondaparinux definitely has its own place. The one for me specifically, and I'm sure we'll talk about this later, is in the setting of HIT. Fonda is one of a go-to, but we can get to that later.
Maybe it's a good moment to talk about kind of what is the world of pharmacologic DVT prophylaxis. Like, kind of what are the broad categories? What's out there? How do we choose between these different drugs?
Yeah, so when you're looking at the world of thromboprophylaxis, low molecular weight heparin, and the big one that we commonly use in the inpatient setting and outpatient setting is enoxaparin for that one. You have unfractionated heparin, and then fondaparinux as well. All of these have been shown to be superior to placebos. There's some data out there potentially for using warfarin or DOACs. They've all been prescribed previously. Warfarin is definitely not advised in the setting of DVT prophylaxis. It takes at least 2 to 3 days to get up to a therapeutic serum level. And by that time, the septic patient who's immobile and ventilated can definitely develop a DVT in the setting and throw it and have a PE by that point in time. So warfarin is definitely not as advised. DOACs have been studied, specifically betrexaban in the APEX study, and it was compared against low molecular weight enoxaparin. They saw VTE rates of 6.3 in the betrexaban arm versus 8.4 in the enoxaparin arm. But however, betrexaban is not readily available in the United States. And again, it's not really standard of practice and hasn't been adopted by most hospitals.
I've already forgotten the name.
Good. Don't commit it to memory. Forget it.
Good.
Just remember enoxaparin.
Beautiful.
And just to clarify a point there, Matt, so those are for people who come in who are not on warfarin and not on DOACs, saying we wouldn't start those meds for prophylaxis.
Yes. If a patient's already on warfarin, they come into the hospital, they get admitted, they have a COPD exacerbation, just continue them on their warfarin, just continue them on their DOAC. You don't need to stop it and start giving them enoxaparin at that time because they're already at a therapeutic steady state for that warfarin. You can assume they've already been on it, floating around in the community for weeks potentially at that time.
And I assume that changes if, like, especially with, with warfarin, it's, I want to say, I could be totally pulling this out of my butt here, but I want to say it's like at any given time, 10 to 20% of patients on warfarin are actually therapeutic, or something crazy like it's like it's difficult to actually for patients to actually appropriately dose themselves. At least it used to be. So I would assume if that's even remotely true, then if you were to get a patient on warfarin who's like woefully subtherapeutic, then you just go ahead and put them on DVT prophylaxis with something like low molecular weight heparin anyway. Is that reasonable?
Yeah, no, I think that's very reasonable. And warfarin's definitely one of those ones it's been around, it's got tried and true evidence for it, but just like you said, it's very difficult for a lot of patients to get into that therapeutic INR. Maybe it's due to medications they're taking that are CYP inhibitors, or they've changed their diet, or they've gone up or down in their weight. I mean, there's a reason these patients are very closely monitored in the outpatient setting, in these coag clinics where they're measuring their INRs. They're fine tuning the warfarin up and down in that setting. And so, just like you said, if they're subtherapeutic and they're coming in, their INR is normal, that's definitely setting or consideration to put them on enoxaparin, and maybe even full dose enoxaparin anticoagulation if there's an indication for why they're coming in on the warfarin already.
Of course, makes sense. That makes perfect sense. Presumably, if they're on warfarin at home, there's an indication for it, and they probably need to be properly anticoagulated and not DVT prophylaxed.
Yeah. Another thing a lot of patients will comment on when they're admitted to the hospital is, "Oh, I'm already taking an aspirin. Why do I need this shot?" And I think that's an important thing to touch on. Aspirin has definitely been good, and it has evidence base for preventing major arterial thrombotic events, stroke, and heart attack. There's really limited evidence to support any antiplatelets in preventing VTE in an acute hospitalized setting. So it's not advised just to start these patients on aspirin. There's studies that are going on providing patients, 81 or 162 milligrams of aspirin post-operatively. But really, it's not advised to start aspirin as a DVT prophylaxis in the inpatient setting.
It's clearly not a substitute for these other options we talked about.
Correct.
So, Matt, that's kind of an interesting point on aspirin and on some of the other options we have for DVT prophylaxis. I was curious. Sometimes folks will admit a patient and lean on let's say. Oh, they'll say, okay, well, they're going to be ambulatory or whatever, so they're fine. They don't need DVT prophylaxis. But is there a scoring system, or are there other strategies we can use to decide, okay, does this person need, chemoprophylaxis or not?
Yeah, there's definitely scoring systems and calculators out there. And the one that I typically reach for is called the Padua score, in determining whether or not this patient is going to be high risk and would merit DVT prophylaxis. Before we even get into that, certainly a lot of these patients are going to have very limited side effects or morbidity associated with mechanical thromboprophylaxis, but it's the use of chemoprophylaxis in determining whether or not low molecular weight heparin or unfractionated heparin being the common inpatient chemoprophylaxis that's given. Like I said, the score that's typically utilized is the Padua score, and it utilizes and looks at those high-risk variables, determining whether or not anticoagulation is going to be needed in a hospitalized patient. And it looks at variables like, do they have cancer? Do they have a history of VTE? Are they obese? Do they have limited mobility at baseline? And any scores greater than 3 indicate the patient is going to be high risk, and chemoprophylaxis is going to be indicated in that setting.
Excellent. And then just for our audience, the specific risk factors that you think about, or risk factors that we should be aware of when we think about, who probably needs to be chemoprophylaxed.
Yeah, first and foremost in my mind is limited mobility. When you think about that Virchow's triad, one of those points on there is venous stasis. And with limited mobility, you can get vascular engorgement and venous stasis, and things that can promote that as well. Things like heart failure, patients with acute respiratory distress syndrome, patients who are septic and hypotensive. And then other known risk factors as well include inflammatory bowel disease, certainly a known thrombophilia, over the age of 60, and like I said before, patients who have active malignancies.
Awesome. Thanks for going through that, Matt.
It sounds like most of our patients in the ICU, if not almost all of them, are going to meet criteria for prophylaxis. That's kind of, we've talked about the world of pharmacologic DVT prophylaxis. Let's shift gears and talk about the world of mechanical DVT prophylaxis. So what are your thoughts on SCDs?
So I'm a supporter of SCDs for a lot of patients if they can tolerate them and they are not at least low risk. If they're up and moving around, the SCDs are essentially doing the same thing that mobility is doing. It's squeezing the legs, promoting that blood flow, trying to limit that vascular congestion, that vascular stasis that promotes thrombosis. Like I said, the methods for prevention of VTE can be given to the vast majority of inpatients, specifically those who you want to prophylax, but they're going to be at high risk for bleed, or they already actively have a bleed. These are patients coming in with a GI bleed, hemorrhagic strokes. Some of those mechanical thromboprophylaxis options include intermittent pneumatic. Some of those options include intermittent pneumatic compression devices. We always call them SCDs where I trained, sequential compression devices, compression stockings, and venous foot pumps. I've seen things before about neuromuscular electrical stimulation, or TENS-like units essentially on the lower extremities. Those are predominantly in trials. But as I stated before, the name of the game is trying to prevent DVT by continuing to enhance blood flow and squeezing the lower extremity venous system, thereby preventing venous stasis.
Sort of the analogy is like a rolling stone gathers no moss, a moving leg gathers no clot, hopefully. How well do these devices work?
So when you look at the rates of IPCs versus no device, one of the trials that looked at this was called the CLOT-3, and they looked at the rate of patients after they had been admitted to the hospital and then 30 days thereafter. It saw rates of DVTs of 8.5% in the patients that had the intermittent pneumatic compression versus 12% of those patients who were not receiving any mechanical thromboprophylaxis. There's even really less convincing evidence regarding the efficacy of graduated compression stockings and venous foot pumps. If you think about it, I mean, compression stockings, you're squeezing that vasculature, but you're not really promoting the utility of and the movement of blood flow back to the heart. And then certainly with venous foot pumps, you're really only getting the lower ankle or the feet. You're not getting those other great veins in the lower extremities. When you look at some meta-analysis data as well, those graduated compression stockings, they've really been found to be ineffective in the prevention of VTE in patients also with ischemic strokes as well in particular. One randomized trial of stroke patients showed that thigh length stockings was associated with no benefit in respect to the reduction of thrombosis in VTE, but it did show a fourfold increase in the risk for skin ulcers and necrosis.
Got it. And what about, if pharmacologic is good and mechanical may be good, what about putting them together? Is there any evidence for that? Two has got to be better than one, right?
Yeah, there's been a couple studies that have looked at that before. The PREVENT study looked at 2,000 critically ill patients. 80% of them were in the MICU, and they gave them intermittent pneumatic compression for at least 18 hours, plus unfractionated heparin or low molecular weight heparin. It did statistically reduce the rate of ultrasound-detected DVTs. There was 3.9% in the combined arm versus 4.2 in the pneumatic compression arm only.
Got it. So two is not necessarily better than one in critically ill ICU patients.
Yes, at least by this study. But in my own experience, a lot of times when I've seen patients who are in the hospital, a lot of trauma services or patients who are critically ill end up being on both. And whether that's due to they're initially started because there's high risk for bleed, or they've had some type of concern for hemorrhagic stroke, and then they're started on Lovenox after they've been deemed to be stable for chemoprophylaxis.
It makes sense if their chemoprophylaxis is being frequently held for procedures and whatnot, which we'll talk more about in a minute. All right. So we've demystified the SCDs a little bit. Thanks for your insights there, Matt. Let's take this case in a slightly different direction now. So let's throw into this mix that the patient has a platelet count of 45. They don't have a history of cirrhosis or any other reason that we know of to be thrombocytopenic. How does that change our approach to DVT prophylaxis? Is there a magic number where we should just say no more chemoprophylaxis?
It's definitely a continuum. 50 seems to be a hard stop for a lot of people, but I think that risk to benefit of DVT prophylaxis and risk for bleed and risk for clot, or certainly clot propagation, needs to be weighed. First and foremost, you need to confirm that the patient actually has thrombocytopenia. So do a manual diff, make sure there's not giant platelets floating around in there that are being calculated and as red blood cells, and so the platelet count's significantly higher. And also grab a citrated tube, because pseudothrombocytopenia is a very, very common etiology for thrombocytopenia. There's also, I think, a big misnomer out there. A lot of physicians believe that having a platelet count at 50 or below protects you from DVT, and that's not actually the case. Having a platelet count below 50 significantly increases your risk for bleeding for occurring. And giving these patients chemoprophylaxis can certainly add fuel to the fire if they do have a spontaneous bleed. There's a lot, like I said, there's a lot of comorbidities that work there, like obesity, limited functional status, if they have peripheral vascular disease, that really need to be weighed in the setting of determining whether or not that patient needs thromboprophylaxis. And I've seen it been given down all the way down to 30 for patients that are not actively bleeding, have significant peripheral vascular disease, and limited mobility. In my personal opinion, may be that the chance and development of risk of developing DVT may be even more dependent upon atherosclerosis and things like underlining endothelial damage in the vascular walls, secondary to long-standing hypertension in these patients. So like I said, when the decision to hold prophylaxis is made, it's not based on the patient being, quote, protected from VTE because those platelets are less than 50, but the risk of them having a spontaneous bleed is significantly elevated. And there's certainly a linear correlation from platelets going down to 50 all the way down to 10 for the chance of a spontaneous bleed occurring.
So, Matt, it sounds like the number 50,000 is reasonable to remember, but it shouldn't necessarily be a hard stop. Rather, it should cause us to pause and kind of make a patient-centered decision based upon that particular patient, their risk factors for bleeding, their risk factors for clotting.
Yes, absolutely. Above 50 is generally considered safe. When those platelets are above 50. There's really limited data regarding the safety of primary prophylaxis in more severe thrombocytopenia. But I think, just like you said, weighing the risks will help us determine if this patient with a platelet count of 45 needs anticoagulation. So certainly this patient in his mid-late 70s has a history of hypertension, platelet count just below 45. It certainly could be consideration to give him thromboprophylaxis, especially in the setting of limited mobility if you think he's going to be in the hospital for several days.
Yeah, I think you make some great points there, Matt. So first and foremost, make sure it really is thrombocytopenia. Draw citrate tube, blue top tube, and confirm. Second, we should view risk and benefit as a continuum. Decreasing risk of thrombosis and increasing risk of bleed, but that has to be customized to the patient. I think those are great points. I think it's also worth mentioning that the trajectory matters, right? So 45, if the next day it's going to be 15, is very different than somebody who's kind of, nadir'd at 45 and the next day it's like 55.
Mm-hmm. Yep.
So, another question, this comes up not infrequently, is the patient that has a diagnosed thrombosis, but then also has thrombocytopenia. So how do you approach that, Matt?
Yeah, so that definitely gets tricky and can sometimes be nuanced, and really going back to that risk benefit of what are the risks the patient has and what's the risk of clot propagation. If this patient has an underlying, say, hematologic malignancy, they're obese, they're active smoker, they have limited mobility at baseline, you're going to be at a high risk for clot propagation. And most people would anticoagulate patients who are at high risk for VTE propagation. Those specific variables include previous venous thromboembolism in the last 30 days, if they have a proximal DVT, if they have a segmental or larger PE, if they have a poor performance status, cancer, known thrombophiliac. But just as there's risk with thrombosis, a lot of the stuff isn't hard and fast on guideline basis. And I always call it the Joaquin Phoenix when he was in Gladiator, when he gave his thumb up or thumb down. I mean, we can look at various risk factors, but really determining whether or not this patient is a very high risk. The patient who's got a hematologic malignancy and their counts are nadir'ing, those are the ones you're going to hold off on. If you're giving those patients platelets every other day, those are not the patients that you're going to want to anticoagulate. But if it's a guy whose platelet counts are below 40, he's obese, maybe he's got ITP and he just threw a big PE and he's got a saddle embolism, I mean, those are certainly the ones that you're going to start to anticoagulate. Like I said, there's no definitive guidelines in this space, but the majority of physicians are going to hold full dose anticoagulation when those platelets are less than 50. Certainly sometimes physicians will give a half dose of full molecular weight Lovenox. So instead of 1 mg per kg BID, 0.5 mg per kg BID. But a lot of it, again, is going back to weighing that risk to benefit ratio of, is this patient going to bleed significantly more if I anticoagulate him? Is this patient going to propagate their clot even more if I don't anticoagulate them and intervene?
Great points, Matt. And by the way, I love the Joaquin Phoenix Gladiator thumbs up, thumbs down is the analogy for clinical equipoise. It's like it could go either way. The dictator is making up his mind. Equipoise.
That's right. Yes. Thanks for sharing that with us, Matt. And then I just want to make sure I realize that we kind of jumped around a little bit, but just for our audience, what we're really talking about in that previous discussion is full dose anticoagulation or modifying full dose anticoagulation, not DVT prophylaxis per se, because we have an active thrombosis. Yeah. Perfect.
Absolutely.
And then, I think that's a pretty good discussion. I guess, are there any other particular thresholds for chemoprophylaxis we should know about? Anything else we should really consider in general?
Not necessarily that I can think of for chemoprophylaxis. I mean, some institutions, if a patient has a significant bleed and they have platelet counts that are low, like 20s or 30s, they will give them a unit or two of platelets to bring that platelet count above 50 and then full dose anticoagulate them.
Interesting. Okay,
Again,
that's an interesting practice.
That's so hard and fast, but that's something I've seen actually even just recently in the civilian sector.
Okay, so great. Let's jump into the weeds and talk about a couple of details. Now that we've talked about why it's essential to do DVT prophylaxis and kind of what the thresholds are, let's get into the specifics. So first off, is there a time of day that you recommend giving them? Is day versus night a better time to administer?
No, not necessarily. I think most institutions are providing DVT prophylaxis in the AM, commonly with the rest of their other medications. There's no specific manufacturer's labels on these anticoagulants at what time to give them. The most important thing is that you're giving them at the same time of day, so you're maintaining that steady serum state during that patient's inpatient stay.
Perfect. And just for our audience, to be black and white about this, is there a specific or standard dose that you use for something like a low molecular weight heparin or unfractionated or?
Yep, absolutely. Lovenox 40 milligrams daily is pretty my standard go-to in the inpatient setting. If their creatinine clearance is less than 30, I'm reaching for a heparin 5,000 units TID.
It seems like there's a significant amount of pain associated with these shots, and one thing we often don't consider is that giving low molecular weight heparin once a day is substantially less painful than giving somebody 3 shots a day of unfractionated heparin. And if you ask patients at the end of their hospital stay, what was the worst part of being here? Many of them will tell you it was those shots in my belly.
Yeah, I don't know of any data that shows an increased efficacy of twice daily over singular day Lovenox or necessarily Lovenox over unfractionated heparin. Certainly in some settings that may there may be data to account for that, but generally their efficaciousness is the same.
Good to know. Do you use coags to help guide your DVT prophylaxis dosing?
No, not regularly. The time that I am following CR markers is in the setting of extreme obesity, sometimes with those patients that have BMIs above 40 or 50. For class 1, class 2 obesity, that's a BMI less than 39. You're looking at standard dosing. So your Lovenox 40 milligrams daily or your unfractionated heparin 5,000 units TID. It's once you get above a BMI of 40 and 50, that's when consideration for split dosing has been studied and been shown to be efficacious. 0.5 mg per kilograms twice daily can be considered in that setting. And really looking at those targeted anti-factor 10A levels with a targeted peak of 0.2 to 0.4 or a trough of 0.1 to 0.2 units per milliliter.
That's awesome, Matt. Thanks for answering that, because I know that comes up not infrequently with some of our patients. Another thing that comes up would be our kind of bedside procedures in the ICU, central lines, things of that nature, arterial lines. Do we need to worry about holding DVT prophylaxis for these procedures?
For a lot of those patients that are acutely ill and you don't have time to wait, 24 hours or 12 hours for their DVT prophylaxis to wear off, you shouldn't be holding, especially for things like central lines or paras or thoras where the bleeding risk is relatively low. These patients aren't fully anticoagulated. You're not doing a major surgery. They're not having their central nervous system violated. And so go ahead and do those procedures, do the central line, do the thora that needs to be done. The rate of major bleeding from a thoracentesis is less than 0.2%, even while on full dose anticoagulation, to give you a little bit of background on that. And as far as testing coags before you're doing these types of procedures, there's no data to really support testing coagulation levels or INR before. Certainly, it's a different story if the patient is severely decompensated, they have DIC or a hyperfibrinolytic syndrome. Say their fibrinogen is very low, you may consider giving them things like FFP before you do. But for the vast majority of patients, go ahead and do the procedure. That's your guys' like standard practice anyways, right?
Absolutely. Yeah, no, I think people are often skittish about doing procedures in people who have gotten a dose of low molecular weight heparin, but I think you hit a key point there, which is that they're getting the procedure for a reason, and the very, very small bleeding risk is much smaller than the benefit of the procedure that they presumably need if you're doing it.
Yeah, like the guy who comes in who's septic, who needs a central line and pressors right away, that's not somebody to wait 12 hours on. Just put that line in immediately and get the pressors going. Don't worry about the small oozing that might occur.
What about, so you mentioned procedures that violate the central nervous system. Obviously, we're not doing a lot of craniotomies, but what about LPs? Like somebody comes in, they're altered, they don't get the LP initially, right? They get a dose of heparin, and now it's like, oh, should we get the LP? How do you feel about an LP after one dose of heparin?
For one dose, you're probably going to be fine. It's if they've got several doses of Lovenoxin, it's probably best to hold off 12 hours prior to the LP. If they've got Fonda, you're looking at 24 hours. In unfractionated heparin, 4 to 6 hours. And one thing to keep in mind, a lot of these patients is DOACs become more and more commonplace, looking at what they're taking in the outpatient setting. If they're already on, a Xarelto or a Pixaban, looking at that and making sure, I'm not doing an LP on this guy as soon as he hits the door because I may cause CNS bleeding to occur.
Great point. All right, let's turn now to like operative procedures. So this person is going to the OR tomorrow for some common procedure, let's say a trach or a G-tube or something. When should we be holding their anticoagulation before that? This comes up all the time.
Yeah, for low molecular weight, you're looking at 24 hours hold beforehand. For unfractionated heparin, 8 hours beforehand.
So potentially you don't even really need to hold the evening dose for a procedure the next day. You just hold the morning dose if it's unfractionated.
Correct. If it's unfractionated, correct.
And I guess if it's low molecular weight, you would just not give that next morning's dose because it's already been 24 hours since the last morning, presumably.
Correct.
So Matt, you mentioned a couple of meds that the person might be on, like if they're on DOACs, they're on aspirin. What other common meds that people are on might affect the efficacy of anticoagulation prophylaxis in the ICU?
Just like you said, a lot of these patients showing up on antiplatelet medications, maybe they have dual antiplatelet therapy for a history of stents, or they're already on anticoagulation for some type of arrhythmia or venous thrombosis. Certainly keep an eye on those. Other things that can increase the risk of bleeding by some of the small primary hemostasis function impacting is actually SSRIs and SNRIs and TCAs. A lot of these patients will show up with low-grade bruising. That's not an uncommon consult that I get in the outpatient setting is bruising secondary to SSRIs. So just something else to be aware of.
Often I try not to stop meds like that, where there'll be some effect of stopping them and some delay in efficacy when restarting them. But in patients with serious bleeds, I usually do stop those SSRIs, SNRIs, because it's theoretically could enhance bleeding.
All right, Matt. And before we move on entirely from this case, another situation we might encounter with respect to the timing of DVT prophylaxis might be in the setting of an ischemic stroke, and then the administration of thrombolytics. So how can we go about viewing that patient and the timing thereof as it relates to DVT prophylaxis?
Yeah, especially in these patients who are high risk with ischemic strokes, they may have paralysis. They're not moving around a lot due to that restricted mobility. Mechanical thromboprophylaxis is oftentimes started at time of admission, especially if they've just gotten TPA. But really, any anticoagulation should be delayed at 24 hours until after thrombolytics have been given.
Got it. That's great. So Matt, we spoke briefly before a little bit about trauma patients, but I want to get into this a little bit more. So now let's move on to a new case. Let's say you have a 27-year-old woman. She's admitted following a high-speed motor vehicle collision. She's got multiple internal and orthopedic injuries that are expected to require a staged surgical repair. Fortunately for her, she doesn't have any CNS injuries. So she's stabilized in the trauma bay and then admitted to the ICU for ongoing resuscitation and monitoring while they're figuring out the operative plan. Her platelet count is 275. How would you approach DVT prophylaxis in this woman?
Thank you. And this is a very significantly important area. And trauma-induced coagulopathy is really an area we could spend this whole podcast discussing on this area. Trauma is a significant increased risk for thrombotic events. If you think back to that Virchow's triad we learned when we were young pups, any trauma-inducing endothelial damage can increase risk for thrombosis. Venous stasis. After a trauma, patients have limited mobility. They're oftentimes bedbound for a couple days in the ICU, limiting mobility as well. And trauma itself is believed to induce a hypercoagulable state through mechanics such as suppressing protein C levels. It alters antithrombin levels throughout the system, and it also drives up platelet counts. When you look at systemic reviews reporting overall incidence of VTE in the trauma setting, 12% of these patients without chemical or mechanical thromboprophylaxis are typically going to have a VTE event, and only 7% who receive only mechanical thromboprophylaxis. And those rates are probably even significantly higher among patients who have multiple injuries or need multiple step surgeries. Certainly, thromboprophylaxis is indicated for hospitalized trauma patients, but the clinical decision on when to initiate that pharmacologic prophylaxis must seriously be weighed against the risk of them having a bleed. The patient comes in, they have a severe solid organ injury, they have a spinal cord injury, maybe a closed head injury. That is definitely a risk benefit at that point in time. One of the models that can be used to assess the risk of VTE in adult general surgical patients is called the Cabrini model. And it uses certain variables like age, comorbidities, any recent surgeries, smoking, obesity, the type of trauma they had, with any value greater than 5 indicative that the patient is going to be at high VTE risk.
That's a great discussion, Matt. And so got it. Obviously, these folks are at high risk. We need to be serious about their DVT prophylaxis. So with that being said, is there a preferred agent?
Most major trauma centers are using lower molecular weight heparin. Sometimes they're getting combined, just like we talked about earlier in the show. Maybe they come in, you can't start chemoprophylaxis immediately, so you put SCDs on them, and then 24 hours to 48 hours later, after they're stabilized, they're not having any need for active surgeries, then low molecular weight is typically coming on at that point in time.
And is there data for mechanical sequential compression devices and other devices in these folks?
Yes, no, absolutely. There's been at least 5 trials that have looked at that question, mechanical versus no prophylaxis, and it's been shown to reduce the risk by about 60% across all 5 of those trials. Pharmacologic versus only mechanical as well. 6 trials have looked at that decrease in the risk of VTE by at least 50%. Noted higher risks for minor bleeding amongst those patients that were receiving pharmacologic prophylaxis, but not major bleeding. And then ultimately, low molecular weight versus unfractionated heparin has also been found to be more effective in decreasing DVT risks in separate trials, decreasing the risk by at least 30% with similar bleeding rates in these patients with trauma.
So just to summarize that, because I think there's some great points there. Trauma patients are at high risk for thrombosis because all that tissue factor is liberated. They have other inflammatory responses to injury. These patients should be on anticoagulation once it's safe to do so, which may often be after 24 to 48 hours, depending on what their other injuries are. And then if you're going to use a chemoprophylaxis in these folks, low molecular weight heparin is probably superior to unfractionated heparin. And there may be a role for both SCDs and chemoprophylaxis.
Yeah, and when you look at some of these studies that have shown, there's been at least 3 combined mechanical plus chemoprophylaxis versus chemoprophylaxis alone. It showed a decreased risk of at least 60% across the 3 trials when used combined.
Great. So we've talked about dosing a little bit so far. Just to remind our audience, how do we dose low molecular weight heparin in these trauma patients?
So commonly, trauma patients have a little bit different dosing than the standard patient who's admitted in an inpatient medicine service. Oftentimes in the trauma setting, these patients are getting Lovenox 40 milligrams Q12 with adjustments based on anti-10A levels targeting 0.2 to 0.4 peaks or a trough of 0.1 to 0.2. The other option is going a weight-based approach, that 0.5 milligrams per kilogram Q12, targeting those same anti-10A levels.
So Matt, it sounds like there's this kind of notion of BID dosing, 40 milligrams, but is that really very deeply rooted in evidence? Is there a lot out there to kind of guide that practice?
I mean, not that I've seen per se. It really seems like we talked about a lot, Joaquin Phoenix effect. Oh, okay, this patient's, like I said, you got 40 milligrams BID is very standard for a trauma patient, but it hasn't really necessarily been shown to be significantly more effective than a 40 milligram dosing. And then as these patients age or they have decreased creatinine clearance, sometimes they'll drop it down to 30 milligrams BID. And those are guideline driven recommendations, but I haven't seen anything that's hard and fast in supporting those decisions per se.
Okay, Matt. So we've spent some time now talking about that trauma case. We see a lot of trauma in the intensive care unit. Another thing we see a lot of is liver disease. So maybe we can roll into a third case and we can discuss another patient here. We'll say it's a 47-year-old male who's got a history of cirrhosis coming in with an upper GI bleed. Platelet count at baseline is 110, but he's coming in at 52 today. So obviously, if the patient's actively bleeding, DVT prophylaxis is not necessarily going to be the first discussion we have, but we'll go ahead and say it's hospital day 4. He's had an intervention. Bleeding's been temporized for about 48 hours. We're now up to a platelet count of 67. So, Matt, could you talk a little bit about the coagulopathy of liver disease and then how on earth we might manage DVT prophylaxis in someone like this?
No, absolutely. I think this is a great question. And it's important to know these patients are not just bleedy. I would say they're also a little bit clotty as well. They can have multiple hemostatic problems occurring at the same time in the setting of liver dysfunction, increasing the risk of both clot formation and bleeding. And it may happen at multiple different stages in the hemostatic process, ranging from fibrinolysis to coagulation abnormalities to impaired primary hemostasis with platelet activation and adhesion abnormalities. Cirrhosis leads to an altered inflammatory level at the endothelial surface. It causes diminished volume of and function of circulating platelets. It can lead to alteration in blood flow, certainly within the hepatic parenchyma itself. The risk for bleeding and thrombosis may not even really be captured by your traditional coags, your PT, your PTT, your INR. There was a Danish study that came out a couple of years ago that showed cirrhotics were 1.7 times more likely to develop VTE compared to the general population on the quote unquote clotty component that they have. And it's thought that hypoalbuminemia actually has a strong correlation with VTE in this population. It's likely reflecting some component of decreased synthetic liver function and the ability to produce anticoagulant factors. In that Danish study with a level of albumin less than 1.9, they had a VTE that was 5 times normal risk.
That's a great point. So we should look at the liver patient as hypercoagulable in general, unless they come in with a bleed. And we should especially look at the hypoalbuminemic cirrhotic as somebody who's at especially high risk. And you make another great point, which is we should be distrustful of the INR. It was a test that was developed to track the therapeutic level of a drug, not really to evaluate coagulation risk in these patients. What do you think, Matt, about using TAG in these patients?
Certainly, TAG has a space in the setting of a patients with liver abnormalities, and it's really been studied in the setting of patients who were getting liver transplants as a ability or a means to determine whether or not they need certain transfusion requirements. That goes to say it hasn't really been studied as a means to determine whether or not to give these patients DVT prophylaxis. You can utilize it as a means to potentially give you more information, but I wouldn't use it as the only factor you're looking at to determine whether or not they're going to be appropriate for chemoprophylaxis.
And just to double click on that, that would be like somebody's got a high INR, lowish platelets, but you do a TAG and the TAG is fairly reassuring. Their numbers are relatively normal.
Yes.
So, Matt, let's have the rubber meet the road here, and let's just ask the question. So how would you manage DVT prophylaxis in a patient like this?
Platelets above 50, not bleeding, DVT prophylaxis is advised. Selection of the anticoagulant that you're using should be the same in cirrhotics and non-cirrhotics. So platelets above 50, not bleeding, I'm going to give them 40 of Lovenox. It's good to assess the risk with a Padua score, again, looking at if they have things like active cancer, previous VTE, if they have bed rest for more than 3 days, if they're obese, and any scores greater than 4 indicate high-risk VTE. Prior study has shown that patients with cirrhotic morphology with high-risk VTE based on their Padua scores were 12 times more likely to develop VTE than those who were low risk. And while low molecular weight heparin remains often a preferred choice for anticoagulation and DVT prophylaxis in the patients with cirrhotic liver disease, it's important to remember that heparin requires antithrombin to inhibit thrombin and factor 10. And since antithrombin is synthesized in the liver, and it actually may be reduced in the cirrhotic with decreased liver function. They may fail to achieve those target anti-10A levels. So that's something important to keep in the back of your mind.
Interesting. All right. Well, that's an excellent discussion of the effects of cirrhosis on coagulopathy, increased risks, and why VTE prophylaxis is so important. Lightning round. So first lightning case, we have a 34-year-old woman with cervical cancer. She's admitted for sepsis from a urinary source. How do you approach this? Any special considerations, Matt?
So first off, patient who's septic, they're going to be high risk. Patient who has active malignancy, they're going to be high risk. So this patient is going to need chemoprophylaxis. And I think it's important to touch on Lovenox has been found to be superior in decreasing rates of DVTs and PEs and active malignancies when you look at unfractionated heparin. And so if you're at an institution that unfractionated heparin is their go-to, the patient's probably going to benefit more from Lovenox in that setting with active malignancy.
So even though the pharmacist is going to say, why can't we substitute unfractionated heparin? The answer is no, this person in particular needs low molecular weight heparin.
Correct.
All right, Matt, let's try another case. How about a 44-year-old male with a history of asthma who's coming in with COVID-19 ARDS? How would you approach that patient?
So coming in, COVID and ARDS are both going to be high risk in and of itself, because especially in the setting of ARDS, the patient's going to be likely immobilized for a couple of days. They may be mechanically ventilated. They're going to be high risk for DVT and PE, so thromboprophylaxis is advised.
I'm going to ask the question, Matt, and you can feel free to defer it. But there was a lot of talk, at least early on in the pandemic, about higher doses of DVT prophylaxis, therapeutically anticoagulating these folks. I know we're not really going to get into therapeutic anticoagulation, but I am wondering, at least from your standpoint as a hematologist, should we be considering changing our dose of DVT prophylaxis for patients with COVID-19 and ARDS?
Not necessarily, as far as I understand from the literature. I haven't seen anything that says give these patients, 40 BID or split dosing or anything like that. As an aside, there was a lot of concern early on that these patients may develop antithrombin deficiencies in the setting of COVID and being on ECMO. And so their anti-10A levels weren't necessarily always being reached. And so these patients would have PTTs that were super far out, but their anti-10A levels would be normal. So I don't know if that's something you want to add in there as a caveat, but that was something I remember seeing like all the time at BAMC. And so they would put them on like argatroban or something like that.
Mm-hmm.
Yeah, I think there was a lot of uncertainty initially about anticoagulation in COVID, a lot of reports of thrombosis and a lot of sort of COVID exceptionalism where people thought these patients are particularly thrombotic. I think when you actually look at it in the context of sick people with ARDS, COVID is probably not much more thrombotic or any more thrombotic. And a lot of the sort of COVID exceptionalism of intermediate dose anticoagulation probably doesn't make sense ultimately. But I think it's a good reminder that sick, intubated ICU patients who are immobile because they have ARDS are very high risk for anticoagulation. And so everything that we've discussed in this podcast is relevant to those folks. They probably don't require some special magic treatment. They probably require the high quality care that everybody in the ICU needs. All right, on to the next lightning case. 54-year-old woman with a history of DVTs who was started on a heparin drip, who now, on a couple days in, has a 70% drop in her platelet count.
So a patient coming in, DVT, started on a heparin drip, 70% drop in their platelets after 3 days. The first thing I'm concerned for in this setting is heparin-induced thrombotic thrombocytopenia. So the first thing to do is stop the heparin. The heparin may be associated not only with dropping that platelet count, but also the reason for why the patient has developed the DVT. So calculate a 4T score. If the score is less than or equal to 2, it's typically unlikely HIT. However, those scores are really only metrics that you should be used. Use your clinical judgment in determining whether or not that this is potentially HIT. The confirmation test is a serotonin release assay. And so typically I'm utilizing that test as well. If I have a high degree of suspicion, if it fits that timeline, the platelet count's dropped by at least 50 and their nadir is typically above 30. And it's really, if they have a thrombosis, then I'm concerned that, hey, this may be real deal HIT. By which time patients you're already switching them onto argatroban drips or fondaparinux, a non-heparin anticoagulant in that setting.
Perfect.
Excellent. Yeah. And I think the key takeaway for people is it seems weird if their platelet count drops that we have to switch them to a different anticoagulant. But I think the key point is to remember that their platelets are dropping because they are forming clots.
Not only that, but like we talked about before, dropping platelets doesn't necessarily protect you from thrombosis. It increases your risk for bleeding. And so we are anticoagulating these patients as a means to decrease that risk or stop the propagation of clot from forming.
That's a really good point.
Another question, just in broad strokes, how do you approach the patient with TTP-HUS? Any particular considerations there?
DVT prophylaxis is definitely advised in that setting. Certainly mechanical thromboprophylaxis should be utilized early on, especially if those platelets are low, like 50 or 30. But going back to the risk and benefit, just like we said, low platelets does not protect you from forming clots per se. It increases your risk for bleeding. I'm typically putting these patients on chemoprophylaxis when they're in the hospital. Now, if those platelets are going low, you're getting low below 30, that's when you got to have that risk-benefit analysis of when I'm anticoagulating, when I'm giving them chemoprophylaxis, am I significantly increasing the risk for a bleed here that's outweighing the risk for a clot forming?
One more lightning question. What about the patient with thrombocytosis? So sometimes you see somebody who comes in, their platelet count is like 600,000. How do you approach this person?
Yeah, certainly patients who have thrombocytosis in the 600,000, they're going to be at an increased risk for blood clot formation as well because they have higher levels of platelets, more platelets floating around, more chance for platelet activation. However, be cautious when a patient has a platelet count greater than 1 million. They can actually get an acquired von Willebrand factor deficiency, and those patients will have a tendency to bleed. And so before starting them on any type of chemoprophylaxis, they need to be cytoreduced or undergo platelet pheresis before we start DVT prophylaxis.
That is a great pearl, by the way. So, when somebody's platelet count is high, it increases their thrombosis risk, except when it's very high. And now their thrombosis risk is lower, but their bleeding risk is much higher. So very good paradox to be aware of, that acquired type of von Willebrand factor deficiency.
Man. Well, Matt, this has been a really great discussion on all things DVT prophylaxis in the critically ill patient. We really covered a ton of information. We talked about why DVT prophylaxis is so important in these patients and different strategies, different approaches to treat them. And then with that, we talked about our options specifically regarding the chemoprophylactic agents available. We talked about SCDs and how those different options can kind of dovetail with one another. We then rolled into some special cases. We talked about a medical patient. We talked about trauma cases. We talked a little bit about HIT, a little bit about TTP-HUS, and just this whole potpourri of topics. So, tremendously grateful for your time and everything here, Matt. This is really a great discussion.
Yeah, I think our listeners are going to get a lot away from this. So thanks so much for joining us, Matt.
No, thanks for having me, guys. I'm delighted to be here today.
We'll have to have you come back. So I just want to remind our listeners that, we covered a lot here. We have links to all the studies that Matt mentioned. We have links to the scoring systems that he mentioned. And we have a summary of everything we talked about on our website under the show notes. We spend some time, each week putting together these detailed summaries. So for people who learn by reading, you can learn critical care time by reading too. It's a great way to review what we talk about on the show. On that note, we come to the part of the show where we like to say thanks. Thanks to our guest. First of all, thanks for joining us. Thanks to our listeners, and especially those who have left us reviews, particularly 5-star reviews, or given us a shout out on social media. It's great to help other people find the show. Again, yes, thank you. Thanks, Matt. It's always great to see a friendly face and to work with a colleague from yesteryear. So I'm glad you made time for us and we were able to tease through this topic. To our listeners, we really hope you guys all enjoyed the show. If you did, please make sure to subscribe, give us a like. Please leave us that 5-star rating that Nick had mentioned. Using whatever your favorite podcast app may be. As you know, this does help us tremendously expand our audience, and it does mean the world to us. Yep. You should also be sure to follow us on every social media platform. You can tweet or X or whatever at CritCareTime, or follow us individually at Nick M. Mark or at Askins_Razor. We're also on Instagram, Threads, Blue Sky, blah, 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 every platform. You should also follow Matt. A reminder that his Twitter tag is Rendo Oncology, RENDONCOLOGY. Yes, please give Matt a follow because he could use all the ego strokes he can get. And I'll also say take this opportunity to thank our sponsor, C-Star Medical. So we are fortunate and grateful that this episode and all episodes of season 1 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Please check them out on their website, cstarmedical.com, to learn more. And before we go, we want to thank our production team. We also thank Kurt Belknap for composing our awesome theme music. And lastly, just a reminder, we have all these materials on our website, including this audio. You're free to use it. You're free to share it, but please acknowledge your source. We just want you to tell your friends where you got it. Yes, indeed. And as per usual, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, last time I'll say it, thank you, Matt, for your time and for joining us this evening. Thanks to everyone for listening. I am proud to still be Dr. Cyrus Askin. And I'm Nick Mark. See you next time, folks.